Rachel Forbuster. We will be recording this session, so you'll have just noticed the records button's gone on by Leanne. So Rachel Forbuster from the Academic Health Science Network for North East and North Cumbria, and I chair and facilitate this digital inclusion forum that we host for our whole region, which is excellent. Please note you can also use CC captions for those who might need that facility on your Teams call. So please do turn that on if you need to. I firstly wanted to just say who we are at the Academic Health Science Network, because not everybody knows who we are or what we do. So we are one of 15 across the whole of the network through the whole country. We cover the North East and North Cumbria. And really what we look to do is how do we support scale and adoption of innovation across health and social care to a certain degree as well, with three key aims around increasing the health of our population, also around how do we generate economic growth in our region, and also how do we transform the safety of our patients. So that as an academic health science network is what we aim to do, and we do a number of different projects and support a number of different things across the region. The majority of our funding comes from NHS England or life sciences, and we act in that middle. We try to broker different conversations and act as an honest organisation to help change happen on the ground. So digital inclusion has really filled out a number of different programmes of work. We're very keen to make sure that anything we do to support in our region has a focus on how do we include everybody and not just those who are digitally able. So we pulled together this forum with really, it's about bringing together people who are like-minded and have an interest in digital inclusion to really share some of that best practice. And for me, it's about those takeaways. You're giving up your time to come and join in and be involved in this programme, but what do you take away and how do you influence and support that in your own organisation or with the people that you come in contact with? And that's the thing I want you to take away from today. So today's session, I am absolutely delighted that Leanne and I have managed to get Matt Atkinson, the lovely Jenny Foster and Sarah Wilson to come along and share a little bit of insight into what they do and some of the great, I guess, projects that we're doing in the region that can benefit wider. But on top of that, we've got Sarah Wilson from Newcastle University, who's really looking at that, equity aspect, and she's going to run through some slides on what she's doing for her PhD, which is fantastic. So we are going to move into our presentations. There will be a chance at each of the presentations for a couple of questions for each of the presenters. And then we will do a very small panel discussion, just so we bring that content to life with some meaning about onwards as well. So please do, pop your questions in the chat function, or when we get to that point, please do put your hand up. But first, I'm going to welcome the amazing Matt Atkinson, who is going to share a fantastic slide deck of one of the many digital projects that he gets involved in. Inclusion's very much at the heart of what he does, and we're delighted that he's been able to give up some time to come and present to us today. So it's over to you, Matt. The floor is yours, as they say.
Thank you very much, Rachel. That was a lovely intro. Good afternoon, everybody. I'm Matt Atkinson. I'm an ambassador for the Digital Poverty Alliance. I just want to share with you an example of one of the many projects that we're working on and some lessons learned that we've got from that project as well. So we saw on the BBC News last week, Elizabeth from the Digital Poverty Alliance was on there talking about 1 million more people crossing over into digital poverty because of the cost of living crisis and so on. And then we know as well that the demand on the NHS is increasing constantly. So the use case I want to talk about today, let's get this working, is this one. And we've talked about this a lot within the Digital Poverty Alliance, is that somebody will go to their GP, and then there's often an assumption, and we're lucky if this conversation even happens, to be honest, but there's an assumption that people have access to digital devices and digital services, and when they don't, there's a problem. And to alleviate that, we often talk about the magic three. So can we supply hardware? If we give them connectivity and the appropriate digital skills, then that's the problem solved. But actually, there's another aspect that we need to consider for a large percentage of those people that are digitally excluded. So that magic 3 will do the job for a lot of people. So it is a good solution. But then we've got this problem. And my good friend Andy Wake, who's also an ambassador, he's on the call today, said if somebody's got arachnophobia, the last thing you want to do is introduce them to a big hairy spider. And I love that comment, because this is the other aspect we're dealing with, is when people are a technophobe, then that's what technology looks like to them. So it's very, very difficult to get them to adopt a piece of hardware, a piece of software, and then take some digital skill training as well. So we've still got this problem. We offer these technologies, but people really, really shy away from them. So we've got to think more simplistic, and this is hence the less is more. Is how can we really get away from technology, especially cutting edge technologies, influencing user experiences or digital inclusion. If we go all the way back to 1967, John Shepherd Brown OBE, he was the guy that invented the cash point, or the ATM. So this was his quote at the time. He hit upon the idea of a chocolate bar dispenser. I used to have one of them as a kid. It was fantastic, one of my best toys. But he said, what if we replaced the chocolate with cash? And the cash point was born. And what we've seen since then is ATMs being repurposed for other things. And I've spoken to a lot of these companies, and a lot of them already have, you can top up your mobile phone here. So you're not just doing cash transactions with a bank, you're actually facilitating transactions with other devices and things as well. But also in talking to them, they're talking about services just as such as Just Eat, for people that are digitally excluded, Deliveroo, and so on. And these things that tend to be within the community outside of the local shop and so on. So it's a very accessible device. And of course, it ticks the 3 boxes, because we've got hardware, we've got connectivity. From a digital skills perspective, they've been around since 1967, so muscle memory is there. People have got used to using this interface, and it's a really, really simplistic user interface as well. Not only that, but we've got languages and support. You can press a button to get help. There's over 52,000 access points across the UK still. And we've got secure 2-factor authentication, because you need to put in a card and enter a PIN. But not only that, it's impossible for somebody to send a spam message to a cash point, because it's a closed system. So it's a very, very secure system as well. So the idea was, well, what if we do this? We just, introduce NHS community health services. We give an option to access those services through an ATM machine. Um, and it looks a bit like this. So if it is a confidential message, you don't have to view it on screen, just print it off. And now we've got a means of, instead of sending a message from the NHS to a mobile phone or a computer, what we're doing instead is just sending it to a bank account. So we're aligning somebody's NHS or national insurance ID with a bank account number. So again, there's, from a data protection point of view, it's not a really big concern. So what are we doing about it? Well, lots of people working in the background. We've got a team of ambassadors from the Digital Poverty Alliance, along with Paul Finnis, who is the CEO of that organisation, focusing on this. I mentioned Andy, who's been doing a ton of work on this with me, who's on the call today. We've also engaged with the ICB, so in the North East and North Cumbria. We've spoken to NHS England, the Academic Health Science Network. We've got Leeds Teaching Hospital interest as well, and groups like the Prime Minister's Champion Group for Dementia, because we learned through Karen at the university, one of the ambassadors at the university, that even people with dementia have the ability to use ATMs when they can't use any other digital device. So that's fascinating, the fact that that interface helps them. Um, we've also spoken to a wide range of different banks. Sorry, just go back one. Um, Loads of banks to get their input. We've spoken to the ATM providers as well. So they're the people that build the hardware and software and the machine. So companies like Cardtronics, which own the most ATMs across the UK. So far, everybody is right behind this. They're saying it's a fantastic idea. They hadn't considered it before. It's a really, really good idea. And then there's organizations like Link as well. So that if we got HSBC and Cardtronics together and we come up with a solution, we can very quickly deploy that solution through the link network to other ATMs and other services. So it looks like a great idea. I spoke to somebody very senior at NHS England about a week ago. I can't use the name because they haven't given me approval. I need to be careful with things like that. But this was the piece of feedback that we had from that person just last week, which kind of gives us a big pat on the back and an extra push to go and get this done. So fantastic support for this already. However, ATMs are in decline. There's 52,000, as I said earlier, but they're in decline because of cashless payment systems and other things. They're disappearing from city centres. But that gives us a bit of an opportunity to repurpose or reuse these devices in rural areas, move them out of the cities and redeploy them and make them more accessible. But what happens when ATMs disappear? Well, this is where we're going with this. It's like, if we consider how this technology can help right now, we're talking hundreds of thousands of people that would benefit from having communications that haven't got communications today. The consequence of that for the NHS is that they'll maintain that appointment. So massive cost saving for the NHS as well, with people getting critical care. Beyond that, what if we're talking to Tesco's about their cash point machines, why can't we talk to Tesco's about the checkout systems as well? And as somebody's checking out and just getting the groceries that day, what if it just prints out a receipt with a message on to say your appointment is due on this date at this location? So again, a very, very simplistic solution. And we're hoping that that sort of user interface or user experience is going to then influence modern kiosk services, so things in bus stops, curbside kiosks, which BT is looking at that sort of technology at the moment. And then likewise, it would influence eventually as the generation shift and technology increases and we have things like 5G technology and 5G connectivity, then we can start to look at home kiosk services, really simple systems, and even mobile at that point. And again, covering off rural or even more rural, and then international spread of these sorts of ideas and technology. Quick drink of water. So I'm okay for time, aren't I? I've just come up with 12 minutes. So yeah, so Steve Jobs famously back in the day when he launched the iPhone quoted Alan Kay and said, people who are really serious about software should make their own hardware. And that was something that stuck in my mind. So as a lesson learned, I thought about this a lot and I thought, well, okay, how do we continue to innovate but create solutions that don't lose people? How can we keep people tied in and keep them really simplistic and that less is more again? And this is the statement that I come up with just in the last week is that people who are really serious about inclusive digital experiences should make simple and sustainable solutions. And what I mean by that is simple so that we don't have to do an excessive amount of digital skills training. It's just out of the box. TomTom sat navs back in the day were like this. You didn't use a user manual. You just got out of the box and used it straight away. So that's what I mean by that. So that was one of the biggest lessons learned on this. And then also sustainable in that we're not giving them out to individuals. There's not a risk that they're going to get broken, damaged, stolen, sold even. It's stuff that exists in the community for the community that people can use and it's widely adopted. So that was it. I'd welcome any questions if we've got time, Rachel.
We have, and Matt, that was excellent. And I'm loving the analogy of the big spider, the
Yeah,
big
I've got to give
hairy
credit
one.
to Andy for that.
Yes, I think that'll resonate with a lot of people because that is the challenge, isn't it? Um, Training, digital skills. You can give somebody a phone, but they can't use it. So
Yes.
we've got to mirror up the digital technology, but with the usability and actually user interface and how we encourage people. So that we're relying on our community and that community spirit to support doing that. So that was brilliant. So thank you. That exciting opportunity out of the box, isn't it? So it's really great to hear some of that thinking. I'm going to open up to a couple of questions, and I'm just going to check the chat function just in case we've got any in there. Just bear with me a moment. You will have seen a couple of comments. Chris Foreman's mentioned about the NHS patient data to Tesco receipts. All solid discussion around data sharing challenges which we know, is a continuing discussion, isn't it, out in the field, and how do we comply with GDPR, etc. Um, and Patrick's mentioned our GPs recording who wants to use tech and those that do not. So that's a bit more of a, if anybody's got any comments on that from the NHS side of things, do pop that into the chat function as well. So it's an opportunity. Anybody who wants to raise their hand and ask Matt a direct question, then please do. I
Rachel,
know
just
I've.
for Patrick, we did consider GDPR, and we said again, less is more. So,
Mm-hmm,
we don't have to give out any personal data. And if we're connecting a bank account with an NHS ID in the background, that's
mm-hmm,
not, of any real use to anybody outside of that network. But all we're doing is giving appointment information. You need to be here at this date and time. So, we feel pretty safe from that point of view. But of course, we've got people like Wally Charlton from the ICB who's shown an interest in this. So we're going to qualify that. And where we really want to get to next is a proof of concept to be able to test this and make sure it's safe and sound, and that we can deploy properly.
Exactly. And start small,
Yeah.
simple
Yeah.
approach, and then build from there. I think always works without a doubt. So we've got a comment from Julie Tucker around the Learning Disability Network. Obviously there are a population out there who can't use ATMs, they struggle with access to banks. We know that a number of more banks are going to be closing. So I guess for me, it's about how do we do something different so that we can continue to support that population. I'm seeing increasingly my local post office who is part of the shop, and that's becoming quite a community hub and focus. So is there something in addition where you can have a kiosk in that type of environment? So it's just trying to think outside the little bit box a little
Yeah.
bit around that as well. And there is a
It's a, it,
question from Alexandra as well.
Sorry,
Yes, do you
just
want
on
to just
that.
add a comment to that, Matt? Yeah.
Yeah, just for Julie. Good to see you again, Julie. Yeah, just on that, we had considered things like post offices. If somebody went in to draw up funds or something, rather than using the cash point, they could print off a receipt again. But it's that confidentiality bit that we need to be careful with. And we get that, 80-20 rule, I guess, if we can help a whole bunch of people with this, but then it frees up more time for face-to-face, manual intervention, then again we're helping solve the problem, I guess.
That's great. Julie, did you have anything to add to that? Because I've noticed you've got your hand raised.
Yeah, I just put my hand up. Good to see you again, Matt. No, it is a really interesting idea. And it is one of those where I'm struggling to think of specific questions because at the moment my mind's just racing, thinking of maybe all of the challenges rather than thinking of the benefits that would go along with that. So I can see a whole bunch of challenges that you would have, but actually the benefit for a whole range of people would be amazing. My the big thing I'm thinking at the moment is, yeah, we can all go and almost automatically use an ATM, but as soon as you add a new function, then we've got to relearn how to use that function. It's like going from the old press your button phone to the new smartphone, isn't it? You've got
Yeah.
you'd have to learn again how to do something. So some of those populations who are using a lot of muscle memory, dementia, learning disabilities, populations, and so on, may struggle to learn that new way of doing it and would need a lot of coaching to do that, I think. But
Yeah.
really interesting idea.
Yeah. I'm looking forward, Julie, to testing a number of different user interfaces, and it could be that it's just as you put your card and your pin in, if they've got the muscle memory and the ability to do that, then the next thing that pops up is you've got a message, do you want to print that as part of your receipt? And they've got to press OK to clear it, things like that, so we can
Yeah.
make it ultra simple.
Mhm.
Great. I'm going to just ask one question out the chat, then over to Sarah Wilson, and then we're going to move on to the next presenter. Just trying to chair, keep to time, of course. One of my skills, I think. So Alexandra mentions, obviously she's very impressed and thanks you for the wonderful presentation, as she would do. But what she wants to know is about, will the system be linked to bank accounts? Because think of a minority of people who maybe don't have access to bank accounts, in particular people for asylum, and kind of, what alternatives would there be for people who maybe aren't inclusive in that environment?
I don't really have the answer to that now. We had considered, we did a little bit of research around, last year the laws changed. Homeless people can have bank accounts now. So, again, there's an advancement and there's more inclusion through that. We haven't got the answers to everything, obviously, but this is, I guess for us, this is more of just a really good lesson learned. We thought more simplistically about something that's existed for a very long time, and how can we take advantage of that technology. And I'm sure there'll be more, as we just having the conversation today. There's a lot of brains on this call. Somebody might go, what about this? And that's exactly what we need. It's just that train of thought.
Exactly, and please pop those in the chat function and we can export that and share it afterwards as well. So that's the whole beauty of us getting together. We're better together. We get collectively bring up more ideas, and that will help influence and certainly inspire Matt moving forward with this. And I think that's the thing with inclusion. We're looking at new ways to continue extending that inclusion criteria, and we can't solve all of the problems, but we're kind of putting that jigsaw together piece by piece in terms of trying to think outside the box with some of those areas. But I think this is a great opportunity. If I reflect back at my granddad, who passed away a few years ago, but he would only ever go into the bank to use his cash machine. He would use the cash machine, he would use his card, but he would go to the town and he would go into the bank to do that, because he didn't use other types of technology at all. But actually that would have been perfect for him, because it would have been reaching out to somebody different, in a different way. And lots of people do use ATMs. So that was fantastic. So final question from Sarah Wilson.
It's more just out of curiosity, really. Have you done any involvement with people in the public and just getting them in focus with things, see if they think about it?
Just through personal networks and things. It hasn't been a proper trial yet, if you know what I mean. We didn't want to take it too far without engaging with the ICB, for example. So we needed NHS sponsors to do this in the right way. We just didn't want to take it too far and kind of get people excited about something that might not turn up. So not really, apart from parents and family and so on, that we've tested the concept with.
Thank you.
Wonderful, fantastic. Well, we're going to move on to Jenny Foster now. This project, it's, when things just align, the stars align and things just fall into place. And we'd had this idea about a year ago about how we do it. We'd had the right conversations with people, and then bang, along comes Jenny and Judith with this project and idea. And what we've been able to do is connect her with the right people to help this come to life. So Jenny's going to talk us through this programme, which is close to my heart. And it's fantastic opportunity for us to take the learning from this and extend and do something much bigger for our whole region. So bear that in mind when Jenny's gone through her presentation. So Jenny, it's over to you with your slides. Thank you.
Great. Thanks very much, Rachel, for that introduction. Just to begin with, I'm Jenny Foster. I'm the network manager of a network called the Children and Young People's North East and North Cumbria Diabetes Network, really catchy. I basically support all of the healthcare professionals that are looking after children, young people and their families living with diabetes across the North East and North Cumbria. And my role is funded by the 8 acute hospital trusts across the North East North Cumbria region via their best practice tariff for paediatric diabetes. So this project is absolutely truly collaborative project, pulling on expertise from across the North East North Cumbria area. Andy Wake, as we've already acknowledged, is on the call, and he's been really heavily involved in supporting us with this project. But it's an NHS England funded project. It's the overarching management is through myself and our network, but we've pulled on Andy's expertise through his work with Town and Community. We have a young people's support group called Type 1 Kids. They are pivotal to this project, and I think their importance is around that technophobe thing that Matt was just talking about in terms of building confidence in children, young people using devices, and I'll come on as to why they need to be using the devices when they live with diabetes. But they've really supported the young people who we're giving these devices to. And one of the hospital trusts has supported us in the initial stages of this project, but we're hoping to get support from more. I appreciate on the call that there might not be very many people who are familiar with diabetes and what it's like to live with diabetes these days. So this is a poster which is available if anybody's interested to get it. It's almost out of date as soon as it's printed, because the amount of technology that's involved in supporting people living with diabetes these days is rising exponentially. And so things like injecting insulin, which was the traditional way, now the majority of young people living with diabetes actually wear an insulin pump. And instead of pricking your finger to get a blood glucose reading, a lot of young people are wearing continuous glucose monitors or Libra scanners. And this kind of summarizes all of that diabetes technology for you. It's the problem with it is that it's the access to this type of technology is quite patchy. And it's particularly patchy in the areas of deprivation and ethnic groups accessing the technology. So NHS England recognised this last year and got together some funding, went out to the ICS regions and said, look, we need to level up access to diabetes technology, so pumps and continuous glucose monitors. We need to level up. We need to ensure that those living in deprivation and those from ethnic minority groups are accessing technology like everybody else. So they came to us in our ICS, as they did with all of the others, and asked us to have a look at sort of particular groups of people that perhaps weren't accessing diabetes technology as well as other people. So we had a look at the data, and in our region, certainly compared to lots of other regions, we have low levels of ethnic mix across the ICS. So we didn't think we could really have an impact in that area, but we did recognise that we've got high levels of deprivation across the ICS, and so we did feel like that potentially we could have an impact on that. What we did recognise, though, is up in the northeast North Cumbria, we are really forward thinking, and our teams are actually performing really well compared to the rest of the country in terms of getting their young people on diabetes technology. So if the NHS England wanted everybody to level up, I think they were pretty much asking everybody to level up to us, because our access is really, really good. However, we didn't feel like we should miss out on this funding, and we should go even further, and then everybody else would have the next level to level up to. So we agreed that actually we could still do better. And so we had a look and spoke to all of our healthcare professionals and said, right, what is it that you think stops a young person and a family being able to access a pump or a CGMS in your caseload? And what they came up with was actually that it's difficult for some families to access this tech because they don't have access to a mobile phone that's compatible with the technology. So a lot of the technology that's being developed these days is managed, so it's controlled by a mobile phone as opposed to sort of a handheld device that's provided with the pump or the CGM. It's actually managed and controlled by a mobile phone. And if you haven't got access to a mobile phone that's compatible, then it makes it really difficult, impossible for you to access the diabetes tech. This is just a little bit about how many families in our region we felt would be able to benefit from this project. 49% of our patients are living in the most deprived or the second most deprived quintile. So we realised that we could have quite a big impact here. And when we actually drilled down and asked the teams how many families they think would benefit, we worked out about 428 families would benefit from a project which would give a family a mobile phone in order for them to access diabetes technology. Our Type 1 Kids project group sort of talked to families all the time, and they'd heard that this was a problem also. They'd heard for lots of requests for help with technology. They said, we really rely on mobile phones to manage diabetes now, and we don't have a compatible mobile phone, and therefore we can't get the CGMS that we want. So we felt that this project will allow us to help make the changes that families need to ensure their children's diabetes care is managed as effectively as possible. So this is kind of the stuff we're talking about for those that aren't familiar. Education packages are all done on apps these days. We've got all sorts of complex technologies that are all monitored and all controlled using mobile phones. This is just a little snapshot of photographs, but you can see there's a mobile phone in every single one of those pictures. So the scoping around this was basically to identify hospital trusts who were who were coming to the end of their mobile phone usage. So they were bringing in new mobile phones and getting rid of ones that had gone through a 2-year cycle or what have you. What do they do with those phones? And it turns out most of them just box them up and send them somewhere to be destroyed or what have you. And the sort of sustainability projects in trusts are very much focused on trying to repurpose and recycle the phones rather than shipping them off to be destroyed. And so we felt like this project could also answer that query as well. So we thankfully made connections with Gateshead Hospital Trust, who were in a process of pulling together some mobile phones that they didn't need anymore. And so we thought, right, great, we'll jump on this straight away. Along with Andy from Town and Community, we made some contacts to effectively and appropriately repurpose the phones, so they're all done to the right certification. We used Type 1 Kids to offer support to the families who were going to be given these mobile phones to, and then myself and Andy and the Type 1 Kids group would manage the project. So really, we want to give all families the opportunity to access the diabetes technology, which is proven to improve outcomes. And we felt if we could make this project work, we could increase access to diabetes technology by 25% across the North East and North Cumbria, which was obviously a massive increase and would show NHS England a good use of the funding that they put in for this project. So the challenges we faced very early on were that we needed to make sure we got access to the right mobile phones, because not all mobile phones are compatible with all the devices. And that's part of the reason why I'm here, which I'm going to come on to. But also there was a lot of questions around data and Wi-Fi, and whether or not if you give somebody a mobile phone, do they still have to pay for Wi-Fi access or data? And we actually met that challenge really quickly, with Vodafone giving us lots and lots of SIM cards for free, 6 months access to phone calls, text messages, and unlimited data. So we were able to offer not only a mobile phone to these families, but also a SIM card. So we launched the project on the 23rd of February. From the healthcare professionals supporting these families, we've had 62 referrals have been referred into the project. That's for 38 phones and 24 laptops. I've focused this presentation on the phones, but we are doing laptops as well, because to manage your diabetes effectively, you need to download the data from all of your devices into software. And if you don't have access to a laptop or some kind of device to look at that, then you're not managing your diabetes as effectively as possible. So we've had 62 referrals in, 38 for phones and 24 for laptops so far, just in the first 3 months. And 55 families have received their devices. So they are refurbished, repurposed mobile phones and laptops from Gateshead Trust. So they've gone through the process of refurbishment and they've landed with Type 1 Kids, and Type 1 Kids have delivered these phones and talked through the setup process of the phones with the families. So within the first 3 months, we've got 55 families now with devices and now being put on the relevant diabetes technology to help them manage their condition. So I'm here today to obviously discuss that project, to let you all know that the project is ongoing, and it's going to be ongoing for until next March. So we'll be pulling everything together, but obviously we really want this to continue. All hospital trusts will be going through the same processes that Gateshead have just recently been going through. So we want to be able to identify where those processes are happening, let people know that this project is going on, and see if we can get the donations of the mobile phones and laptops through into this project, so we can ensure that we have enough phones and laptops to meet the demand over the next few months. We've currently got 50 compatible phones ready to go, but we're down to our last laptop. So we are looking for more donations as we speak. So there is a poster, which is basically a plea for more compatible mobile phones. We've had a few hiccups with a batch of mobile phones coming through, which ended up not being compatible with the most popular referral that had come through for a particular type of diabetes device. And so we're going through a process with the diabetes device company to get the compatibility linked, There's lots and lots of work going on in the background to make this as smooth a process as possible. So that's the poster. We are in desperate need of iPhone 7s, Google Pixels, and Samsung Galaxy S8. They are the phones that are most compatible with the most diabetes devices. So any one of those phones, if we were to give those to a family, would mean they could access whichever diabetes device that met their need. That's their choice, but also their healthcare professionals' advice. I think that's it. I've whistled, stopped, toured through it, but happy to take any questions.
That was great, Jenny. You know, it's amazing how connecting those right people together, collaborating, can make a real difference to patients. And it's great to see the number of devices that you've already got out there. What I'd like to just add to this programme is the Academic Health Science Network are overseeing and facilitating, trying to increase the size of this across the region. So we've connected Jenny in with all of the trusts through the Innovation Forum, and because actually we need everybody on board to look at how do we get the right device to the right patient. So it might be that one hospital in Northumberland has Google's phones that they're not using anymore, and actually if we can get them to the right patient, and some of the devices that Jenny's got access to might be relevant to a different pathway. We are working together, Matt Atkinson supporting this with us, and we've mentioned Andy Wake a few times, who's on the call today from Town and County Community. So, you know, we're working together to make a difference. We're doing the right thing for our region. And what we're working on in the background is all of that, the legalities, the GDPR aspects of it, etc. So Jenny's helping us navigate what that space looks like. And then how do we make sure that each trust that comes on board to work towards that common aim and goal, it is working in that right way, so that they're confident that the data is safe, that the phones have been wiped in the correct way, etc., etc. So it's just to give them some reassurance to those. But if we've got any trusts on, you know, on the call today who want to reach out to us, then please do. In the first instance, through myself. And then we'll make sure that we connect you with the right people, and then we can have and set up that meeting. The last week, I have had a meeting with renal about involvement in this programme, and we've also got a meeting with maternity this week. So we're seeing an increasing number of people come forward with clinical pathways where their patients would benefit. So that's the work. But Jenny, bless her, she's the one in the front line at the moment, helping us to establish that, to learn from that, to develop that playbook, so that we can lift and shift and increase the accessibility for all. So Jenny, just yes,
yeah, I was just going to add, actually, Rachel, it's probably along the lines of what you just said there, is really the idea of this will be to pull together a project plan at the end, and Andy's really helping us with that, to be able to just pop this into any kind of condition. Obviously, with pediatric diabetes, the level of technology is high. And so this is a really great place to test the waters. But we've already had loads of little changes to pathways. We've had risks appear and that we've had to overcome. So we're putting all of that together in a end of project report. I mean, I keep saying end of project, but hopefully we really don't want this to end. We hope that it'll just become something that's sustainable and just keeps on going. But the kind of funding from NHS England will come to an end, and so we will need to round it up into a project. But we'd like to be able to just hand that out to anybody to say, look, this is what we overcame, this is how we did it, this is the processes we use. You know, you can redo that in whichever area you work in.
And that's our ambition, sitting in the background, certainly between Andy, myself, Matt, and my director, David Belshaw. So that's what we're really keen, is to drive this forward, but for our region. And because, you know, you've talked about that 49% of deprivation with that population of patients with diabetes, that is prevalent in other areas. And how do we get the devices out? And I will throw a couple of challenges when we go into panel discussion around the Wi-Fi accessibility and things to our panel members, because I'm sure they'll give you some food for thought to take away as well today. So I'm opening up the floor. We've got about 5 minutes for any questions for Jenny about this programme. So as I've mentioned before, you can pop something in the chat function, or you can be brave enough to raise your hand and ask a direct question to Jenny. Anything?
I'm just having a look in the chat, Rachel. There's quite a few questions. Do you want me just to answer
if
some
you're
of
happy
them.
with that. Yep, so there's one from Julie Tucker there. Do you want to start with the
Yeah.
one from Julie Tucker?
Yeah, I can do. So the 6-month funding for data, Julie, the Vodafone SIM cards are for 6 months, but they're giving us an unlimited supply. So once the 6 months are up, we can give them another SIM card. And we've only contacted Vodafone so far, but Three and T-Mobile and I don't even know if they exist anymore, but all of the other ones are happy to give us SIM cards. We just haven't got them yet because we just don't have that number of need at the minute. I think we've got something like 600 SIM cards just sat in a box waiting to go out. So that is, we can just hand out as many as is needed.
Great. And then there's one there from Joanne Smith.
Yeah, so we have to you basically saying don't wait till the end to plan and collect the information and data. We have to update the ICS every month, so we do monthly reports in through the ICS. So that's for the national team for NHS England, because obviously they are funding the project, but also locally within the North East North Cumbria ICS, they've got like a digital innovations. They've got 5 projects on a digital innovations network thing going on, and we're one of those 5. And so I have to update them monthly as well. So there's lots of updating going on with this project across various different networks.
And then just to add that, Andy, can you come on the call and just rather than just the written, just introduce yourself quickly and respond to some of the things that we're doing in the background, please?
Well, I certainly can.
Put you on the spot, Andy.
Well, no change there, Rachel.
No.
So, yeah, it's something we've been working on for some time in education, as that's where it all started from in 2020. And it started from the lockdown and all the kids who didn't have computers at home and were missing out on education. At the time, I was a school governor at Aim High Academy Trust in Huntley Spring, where I grew up originally. My background's in programme management and large projects, national and international, and I actually did this years ago for the national grid back in the late 90s. I thought, we should be doing this regionally at the least, if not nationally. But everybody seems to be doing it in a very siloed way. And I thought, well, there's got to be a better way of doing that. And we've all come together. And I think with the Digital Poverty Alliance, what Matt and I have been involved with for a few years now, it really is pulling everything together as a national initiative rather than just a local or regional. But I suppose what we've done is the bottom-up approach, where the DP has done a top-down approach, and we're hopefully meeting somewhere in the middle. So what's working in education is starting to work in health, and that ticks the big box. What we're trying to do for the whole region is to make it get the standards together, make sure that everyone's educated and aware and trained what needs to be done, and provide a centralized service, a hub, so you can repurpose your equipment through the hub, but also you can get all the help through that hub as well. So that's the mission that we're on at the moment, which Matt and Rachel and Jenny and the team's just really launching out on, because it's still early days. But I'm sure we'll get there, because I've seen this before, and I can see where there's momentum, and I can see where we're going. I've got a clear vision of what it looks like. It's just going to take a few years to get there. It's not going to happen overnight, but I think we are creating some good pilots and proof of concepts here. So yeah,
That's great.
I put a few notes in there. We are actually creating a framework, and so it's a governance as a service framework with a lot of the services that you would need to do to repurpose equipment as well. Just take the pressure off everyone and just put it all through one. That's where we're going. So everything we get from what Jenny's doing and with the team, everything what Matt's doing and all our lessons learned, it'll all be fed through for the whole region. So we're not doing the job half a dozen times. Just do it once.
Great. Well, thank you for adding that to. I thought it was really relevant to bring it in, Andy, just to explain what's going on in the background. And governance is highly important, as we know. We've got to assure anybody who gets involved in that programme where data is, etc., how you get them wiped, how do I get a certificate, etc., etc. So that actually we have got a scalable solution moving forward. And Andy talks about years, but really under what we would like to choose in the HSN is by the end of this year, we've got an offer and a proposition, which then begins to run for a number of years beyond that. So that would be our ambition, because I think we need to act quickly. You know, Matt talked about 1 million extra people have gone into deprivation and don't have access to broadband. So we can't really wait years to do things. We've got to kind of balance that and say, what can we do logically, simple, that's sustainable, and that's what we've got the appetite to do now. So Andy, just a final comment to you. You've got your hand up.
Yeah, just to say the reason I said it took years, because when we started, and I'm going to make this public now because we're allowed to, we're doing it with Nissan. All of their computers being repurposed through Town Community and STEM Learning Network and the Computer Hub. So we're basically educating the educators and providing each computer room in the country for the primary school level will always be fully stocked with computers, and the same's happening with secondary school. And it'll be replenished every time there's a refresh. And the refreshes are happening at about 25% annually. So there'll always be a throughput. And it's just the same thing that we're going to be doing with the health. It's just refresh the National Health Service computer equipment. Same thing, different pathways, different customer base. But yeah, it's just repeating what we know works.
Which is great. Well, thank you for that. Thank you for that. There's just a couple of questions for Jenny just before we move on to our final presentation from Sarah. So Violet was asking about, will the patients be given support after the project ends, and is that through your type 1 kids? So just any thoughts on that, Jenny?
Yeah, so again, we're kind of reluctant to say when the project ends, because we hope that this is just going to be continuous. So type 1 kids are a support group, but that we as a network support anyway. So those young people are provided with opportunities to come together at events, and also the support workers within type 1 kids support the families either in their home or over the phone or what have you. So the families are continually supported anyway. And they'll also be supported by their healthcare professionals. They're seen in clinic at least every 3 months, and then have contact with the healthcare professionals in between that. So alongside the support that type 1 kids will be giving them, their healthcare professionals continually support them throughout their life as a young person with diabetes type 1 or type 2. I'm trying to answer some of the questions in the chat as well as we go along, because there's quite a few, but I'll do my best, but happy to take questions at the end in the panel if there's time.
You've responded to Patrick, and things like, you know, the medicines that's available change all the time. Like Libra, you had to buy yourself as a patient, but now they've licensed that for prescription. So there are changes all the time. And as you said, you print your poster and a tentative date the next week, because things do change regularly. So that's great. So Jenny, if you could just answer any other questions in that chat as we go along. I'm going to move on and introduce you to Sarah Wilson. So Sarah is well, our wonderful academic on the call today, bringing a different perspective. I'm sure she's going to take quite a lot of learning away and build this into the work that she's leading on. So she's a research assistant and a PhD student, and she's looking in particular at digital health equity. So anything that we've got to be able to feed into Sarah, I think longer term when she publish, will really help the system wider. So we're going to pass over to Sarah. So Sarah, I've said this twice already, but the floor is yours. Please do share your slides, and we'll come in back at the back end for some questions and answers.
Thank you very much. As already mentioned, I'm a very busy woman. Got 2 roles at Newcastle Uni, but I'm going to give a bit of work that we're doing around digital health equity and a little bit about how I got into that space as well. So the project that I'm a part of is the EDA initiative, which stands for the Early Detection of Neurodegenerative Diseases. And it's a massive project that has more than 60 experts in it now, has loads of different universities around the world involved, and has quite a lot of money behind it, which is always very nice. The big aim of the project is to try and use digital technologies such as smartphone apps and wearables to detect modalities such as cognition, sleep, and language, to detect modalities associated with the early detection of dementia-causing diseases. Then in the end, we can implement a digital tool within healthcare systems that can detect dementia-causing diseases before it's like the symptoms are actually there. And this will also help us move away from the expensive and invasive digital tools and the early detection methods that are currently in use, such as MRI scans and spinal taps, which aren't really that great. And my particular role within this project sits within the Health and Systems Engagement Group. And this group sort of looks at making sure that we're providing evidence and following the regulatory bodies out there. So in particular, the NICE evidence standard framework for digital health technologies. So then later on in the project, when we're ready to implement it within health by NHS checks and things like that, then it's can like run smoothly and we're providing all the evidence that's needed there. And as you can imagine, there's quite a lot of work that needs to go behind this, lots of different aspects of work and everything. And the work that I'm heavily involved in is the healthcare professional work, the risk communication strategies. So if the Eden toolkit comes out with a 10% chance of developing dementia in 10 years, what does that actually mean to someone? And we need to make sure we're building a strategy to make sure that's communicated properly with people. And I'm also heavily involved in the patient and public involvement work, or PPI for short. And then the area that I think is the most interesting and most important is the work around digital inequities. So the spark for looking into digital inequities actually came from conducting two pieces of work. So one was around the patient public involvement work, so the PPI, and this basically involved us going out and asking 9 people with various cognitive impairments and their carers to use the technology that's involved in the Eden toolkit for about 2 weeks. And this technology sort of included different smartphone apps and different wearables such as a Fitbit. And at the end of the 2 weeks, we asked them what they thought of the technology. And basically, one massive common issue that was coming across is people didn't feel comfortable or feel confident in using the technology. Such as one person said, yeah, I'm computer illiterate. Wearing a Fitbit every day is fine, it's just like wearing a watch. But the whole malarkey with a phone, I didn't understand. And this kind of came from having to sync the Fitbit with a phone every day using Bluetooth, just to make sure that that data is synced across. And this was a bit like technically challenging for some people. Even though like I gave them quite a lot of support, they just still found it a bit challenging. Another area as well that we sort of realised was not everyone had a compatible phone to support one of the smartphone apps. So if this was done on like a larger scale or even implement within healthcare systems, it isn't really great because we'd end up excluding a lot of people. And then also when I spoke to 18 healthcare professionals, the concern that would exclude people who are already in digital poverty was quite common, and it just had like further highlights the need that we need to do some work in this area to mitigate the chance of contributing towards digital health equities. And this is where my PhD comes in. So because digital technologies aren't just a dementia related approach, it's used for various different things such as video consultations with doctors and aid in care for different conditions such as diabetes, like we've just heard, and cardiovascular disease. My PhD doesn't just look at dementia, it looks at a whole wider scope, so we can use strategies to promote digital health equity across all of healthcare. And the approach that I'm taking here is to look at 3 key questions. So the first is what causes digital exclusion. The second is who's most at risk of digital exclusion. And the biggest, most important question, how do we mitigate against digital exclusion within healthcare? And now I'll go through the answers I've got to question 1 and question 2, that being informed by a literature review. And then I'll also touch a bit about how we plan to explore question 3. So what actually causes digital exclusion? Well, it's typically caused by unfair differences in access to technology and connection signals such as Wi-Fi, which then affects someone's access to online health services. It's caused by differences in sensors that are used within digital health technology and bias in artificial intelligence models, which then produce unreliable data from healthcare technologies across different demographic groups. It's caused by low motivation to use digital health technologies for various different reasons, like we've heard for today, like such as the fears, and also the limitations that someone might face to actually using the digital health technology. So there's actually quite a lot of different groups that are so like affected by digital exclusion and at risk of being digitally excluded. So what I ended up doing was building this nice little acronym here, CLEARS, that summarises the socio-demographic factors that are associated with a high risk of digital exclusion. And this includes cultural
We
factors.
did this over a year ago. I was going to ask Talwyn to just. Oh, I'm so sorry.
Sorry about that. So it covers cultural factors, limiting conditions, educational attainment, age, place of residence, and socioeconomic status. And I'll go through a bit more information on each of these. So the cultural factors that are associated with digital exclusion are a person's ethnicity, the language they speak, and their religion. So someone's ethnicity can put them at higher risk of digital exclusion due to the unreliability of digital devices across different demographic groups. So there was one paper that was published in 2021 that actually revealed that the different wearable heart monitors, which is a Fitbit, has a 61.2% reduced reliability of the results just because the sensors that are used within the Fitbits and the heart monitors aren't sensitive enough for different skin colours. Someone's language that they speak can actually affect the use of the digital technology, because if they're not fluent in English and it can't be translated to a different setting easily, then they might not just use it because they don't understand what it's saying. Or if it uses a lot of medical jargon or technical jargon, people get put off by using it because they just don't understand it or comprehend it. And religious beliefs can actually have an effect on someone's ability to access and use technology. For example, people in a strict Muslim family, women are like prevented from forming relationships with people outside, like men outside the family and outside the marriages. So this then can then lead to limitations on access to technology, because if they have access to, say, a smartphone, it can easily form relationships through, say, Facebook or Instagram, things like that. And I kind of want to prevent that in really strict families. And there's also a religious day within the Jewish community called Sabbath, and they try and avoid technology use within that day because it's more of a relaxing day. So we need to be considerate of those beliefs when we're building, like with data collection windows and all these, when we're designing digital technology. And then the two main limit conditions that keep on coming across in the data, in the literature, that affect digital exclusion are visual impairments. So if someone's got a visual impairment, is that they're reading stuff on a screen, it can be really difficult for them. Definitely if they can't zoom in or change the font size. And someone with a hearing impairment might be less likely to use a phone call as like a remote digital health service because they can't hear it. Or if you say you've got a Fitbit and it's giving you an audio command, people find that really hard to like pick it up and hear it if they've got hearing impairment. If you have a lower educational attainment, then you're less likely to have access and use the internet than those with a higher educational attainment. And this just might be because you don't know what services are out there, you don't have the educational skills there to help you with the digital literacy skills, to able to use and want to maintain the use of digital technology. And also you might not be aware of the benefits of the digital health technology. So if you don't know the benefits, then you might just think, why is the point in me using this? Which can then obviously affect adherence to using tech for health purposes and reduce motivation to use it. If someone's over the age of 65, they might be likely to be digitally excluded because they might not have internet connection at home, or they might not have access to the appropriate devices. And this is often caused by reduced motivation to use tech, whether it's to do with fears of scams, or whether it's to do with having poor digital literacy skills, not be able to use the technology and having the support system there to be able to use it. Or again, it might just be because they don't know that a digital health system is out there that they can take advantage of. So if they don't know that it's there, they're not going to use it. And then where someone lives can also affect the chance of being digitally excluded. Definitely if they're in rural or deprived areas, because the signal to Wi-Fi could be patchy, or when they do have connection, it can be very slow, which then can affect like some online health services. Like a video consultation with a doctor requires high connection speeds to get the audio, get the video all set up and things like that. And if someone has like really poor connection speeds, they might be thinking, oh, what's the point in using a video consultation when I'm not going to get any advice because it's going to be static all the time. And also, if someone is homeless, they're likely to be digitally excluded because they have a high turnover of phones and phone numbers. So if they go to a GP and get the next GP appointment over the text, then they might not actually receive that because they've changed the number within that time space and they haven't updated the doctor's surgery yet. And also, if they do have a phone, it's less likely to be a smartphone. So it's likely to be one of those old phones that don't have access to the internet on it, and all it can really do is receive and give calls and receive and give texts. And the last one in the framework is having a low socioeconomic status. So those with a low socioeconomic status is a bit obvious. They don't have the money there to be able to afford the fixed broadband fees that keep on rising. they're not able to go out and just splurge on the new smartphone, so they might not have multiple devices around the house that have access to the internet. And there was a report, I think it was published in 2020. It was a Welsh Scoping review by Hunnam et al. And they basically highlighted that the most likely route of internet access for those who are like on a low socioeconomic status is via a pay-as-you-go smartphone. And if you're on a pay-as-you-go phone, then it's usually you've got limited data plans, and you're going to limit the amount of things you're going to use for an online service. Because like having a video consultation with your doctor, that'll take up a lot of data. So you're likely not to be able to use it because you think, oh, I'll save that in case I need to message my partner about the kids and things like that. And that's the CLEARS framework. So that was a lot of work and a massive literature review summed up in 6 slides. And then for the last question in the PhD, we're going to triangulate 3 pieces of work to try and produce recommendations for digital inclusive strategies that can be implemented within healthcare systems across the whole board. So the first bit of work is actually a bit of work I'm writing up for publication at the moment, and it's a systematic review looking at strategies to support digital health equity amongst the CLEARS demographic groups, and also highlight the facilities and challenges associated with these strategies in the development, design and implementation of them in healthcare systems. And this has actually been accepted for a presentation at a conference in July in Amsterdam. So that's pretty exciting. And it also means that the CLEARS framework is now citable, which is the citation at the bottom. And then the next step is to get the opinions of different CLEARS populations and further modify the strategies with them to make sure it meets their needs. And then we're going to take these recommendations and present them to different stakeholders, such as policymakers and different community workers, to make sure different communities with different resources available will be able to implement strategies to support digital health equity. And then hopefully all of that will have a nice little report that we can provide to people and different researchers and different communities so they can follow these guidelines to support digital health equity. And that's everything. Thank you very much for listening. I'm open to answering any questions, and there's my email and Twitter if you think of any after this call as well.
Well, I just want to give you a clap there, Sarah, because that's a brilliant piece of work. And actually simple approach, you know, because we often worry about that academia. It goes into far too much detail. It's not understandable for people, you know, go back to keep it simple. And that's one of the key messages for this group as well. It's about how do we keep that simple. But I love the, you know, the clears. I think that's really clear. And it will bring us on to a question, you know, it's about how do we raise awareness of that amongst the people that we work with, and that simple approach. And it factors in other, you know, it's not just about race or disability, it includes socio-economic, you know, because digital inclusion is much wider than just some of those EDI topics, and it's about how we really take that forward and support you. So I thought that was an excellent presentation, and I know we've got some things in the chat you want to glance at, but we've got some hands up for questions already, so I'm going to move straight into that Q&A bit, and we've got about 5 minutes before we move on to our next agenda item. So let me ask first, I'm going to do it in order. Rachel Austin, so do you want to just pose your question to the lovely Sarah? Thank you.
Hi there, thank you, Sarah. It's more of a comment, really. It was really nice to see an acronym, you know, spelling out lots of the barriers to people becoming better digitally included. I work for Hartlepool Deaf Centre, so I support the deaf community, which are predominantly deaf British Sign Language users. And I've been involved with delivering 3 deaf digital inclusion projects with our local mental health trust. And we've gathered an awful lot of learning, but really a comment I want to say, with so many different elements of NHS professionals in this room, is that one of our challenges is the existing and long-term barriers that deaf people face, really as a form of discrimination against accessing NHS services as it stands, and trying to sell digital solutions when an NHS solely relies on telephone contact and still can't manage to allow a deaf person to text a GP when a GP texts them, or the hospital trust on the appointment letter says you must telephone this number or you'll lose your appointment. And so really for me, there is a review of the legal requirements around the accessible information standards from 2016 that all NHS trusts are failing, and NHS England have been taking their time carrying out a review. But there was a review last year from Sign Health, the deaf health charity, and I would suggest, Sarah, have a look at that and see the existing barriers to fairly standard NHS services across the board nationally. And the last thing I want to say about BSL users is that they have a higher prevalence of disease and illness, and the only causative factor of that is a lack of access to services and to communication. So we have higher levels of type 1 diabetes, and it's more likely that they will be going untreated. So we need to be including deaf people as we go along, as we're developing these strategies, because all the good practice that you will do to include a deaf BSL user will help to include someone who has English as an additional language, or lots of other learning disabilities, things like that. The more accessible we can make things, the better it is for everyone. So I've took your email address, Sarah. I might get in touch.
Yeah, that's great. Thank you for the tip.
Yeah, and I think that's really, you know, obviously it was a comment from Rachel, but that it's so poignant, isn't it? So Sarah's done this and included that, you know, excluded group of people, and there's a great response there. And that's the beauty of this group, is about how do we connect the right people so you can make a difference moving forward as well. We've got some great comments in the chat as well, Sarah. So we've got Violet Rook, who's talked about actually it's a great piece of evidence for any future reports as well, and how do we build on that. So I think that's absolutely fantastic. And you know, we've got lots of other people who would mirror those things. I'm going to move on to Andy Wake, who has a question as well. Andy.
Yeah, thanks, Rachel. I'm just wondering, Sarah, are you connected with the Digital Poverty Alliance in any way?
Not yet, no, but I would like to.
Well, I think what you're doing would definitely evolve what they're doing for EDI, definitely. Because what I've seen is, from being involved from the outset, I think definitely the disabled community is not getting served anywhere near as well as it should. Simple as that, regardless of your condition. And you know, I've got a bee in my bonnet to get that sorted. With on this Thursday, they're actually launching their action plan, which has been best part of 3 years in the making. So executing on digital poverty inclusion for all, and that includes for all. They still haven't got enough research, I think, anywhere near enough for what you're doing. So if we can, you know, catch up after this, be good just to have a call with you and get you involved, because what you're doing is amazing. I just don't think we've got enough of it.
That'd be great. Thank you. Do you want me email? I can put it in the chat if you'd like.
Yeah, I'll do that.
Thank you.
Perfect. Well, thank you, Andy. We've got time for one more question, and we have a question from Chris Davidson.
Thank you. My background is, before I became a lecturer, I was a dementia nurse specialist, and I will say, to comment on what Rachel was saying, it was absolutely crucial that I made the links with the deaf community. We also had a good link with our ECLO, who worked for the RNIB in our iClinic liaison. So if you're looking as a PhD student or graduate, and apologies in here introduction, maybe looking for connections, ECLOs are usually quite good for pointing you in the direction of this people's general sight needs, but that apply to people who have dementia as well. What my question was, are you finding now that people who are coming to the age where there's a greater risk factor for dementia are actually more reliant on technology, or whether they, and then there obviously will become a point where unfortunately they forget what a phone is and what it does, etc. But do you I feel like when I was at the peak of my working in the NHS, we were sort of dealing with a generation who didn't have a phone. Now I'm dealing with a generation who are quite digitally able, but they're making use of it to to manage their dementia. I'm sorry that's such a lengthy question. It's typical of us lecturers, isn't it? But does that make sense?
Yeah, it does, yeah. In the little bit of work that I have done with people with dementia, one of the comments that we had from one of the carers actually is that they gave someone, when they had like early dementia, so it was like the mild cognitive impairment phase, they gave them a phone at that sort of point to sort of help them in any remembrance. To say if they were confused at one point, they would just give them a call and be fine. But what they actually found out is that like over time, they'd have to keep on like relearning how to use the phone, just the way that the memory like sort of declined. So it's more of a case where I've been talking to people who have got dementia and things, and basically they've been saying a similar thing, is that because it's been a bit later in life that they've learned how to use a phone, that's kind of one of the first things that go kind of thing. So I think we might get to a point like say when my generation hits that age and we're developing dementia, it might not go because we've sort of been brought up with it. But at the moment we are sort of seeing it where it's a new thing for people to learn.
Thank you. I thought I'd take that was very selfish of me, wasn't it? I thought I'd take the opportunity while you were here just to ask you that question because it's something I've always wondered. So thank you everyone for bearing with me.
Yeah, not selfish at all, Chris. That's the whole point of this forum. We always want to have that little bit of discussion, which is why we always open up that chat function. And it is about bringing those questions together, but and for people to take things away. So before we move on just to a little bit of a panel discussion, I just want to pick up a couple of comments in there. We've got Alex Wood who joined us today, which was the gentleman I had a really good chat with last week about renal, you know, and highlighting in Sunderland that proportion of people who don't have access to digital technology, but they've got a group of people who regularly come in for, you know, obviously their treatment. So how do we reach out to them? So that's next on our list, and we're meeting up with Andy Wake next month to kind of look and see how we apply that Jenny Foster's application of how you get the repurposing technology out, but for that group of patients. So just wanted to have a shout out to Alex for connecting with us and wanting to do the right thing as well. So thank you very much, Sarah. That was an excellent presentation. It's caused lots of stir of discussion and lots of connections, which is fantastic. And it'll be great to see how we support you moving forward with that as well. So we're moving on just to a little bit of food for thought. So if I can have Sarah, Jenny and Matt with your mics off, please, so you can join us. There are no more muting. And I just want to, my first reflections are, you know, we've got the power of this group. We've already, you know, connected some people, but where do you think collaboration would be an opportunity for particularly, you know, the work that you are focusing on, but for the rest of the group? So I just wanted to get anybody's thoughts on that.
I think something that springs to mind for me, something that Sarah said about testing, you know, connecting with the end audience and things is it's critically important. You know, that's where you should start, and you should learn from different personas and use cases and things to be able to make sure that you're developing the right solution. So, you know, hence connections and all that, Sarah, you know, how can we join the dots and team up on this?
What about you, Jenny, when you're thinking about collaboration? You know, you've brought a number of organisations together to help you achieve your outcomes that you're aiming to get. What's your thoughts for other people on the call?
I mean, we couldn't have done it without the individuals that are in the group. It makes the job quite difficult sometimes because you're bringing in lots of different people from different places, but everybody has their own expertise. I think from my point of view, we are trying to answer a sustainability question as well around the use of tech. So for me, it's a reach out to anybody who has access to chunks of mobile phones and laptops that are not needed anymore. Let's really focus on that as an environmental issue as well, and ensuring that they're repurposed for lots of different reasons. So that's my reach through the Academic Health Science Network. I think that's my ask. And I would collaborate with welcome any collaboration with anybody, and further discussions about how we can involve you in the project if that is something that you've got access to.
I'm going to move on to PPI. So it was very prevalent in Sarah's presentation, and Jenny touched on it, as well as Matt. You know, you've got to talk to the people who are going to benefit from this and understand But what's your thoughts, kind of like, how do we get people involved in that design phase, to that understanding phase? So over to you, Sarah, to maybe answer that.
Yeah, so it's quite a hard question depending on who you're looking at. So at the moment, I'm actually trying to recruit the clears demographic groups for the second bit of work that I'm doing. And we're actually finding it quite hard because you have to engage people who this kind of thing might not be on the top priority. The top priority is putting food on the table for the kids at the in deprived areas and things. And it's sort of finding those right networks, finding those right gatekeepers and all this. And it's a lot of work to go behind it. There's a lot of different times you send out a load of emails, you don't get much back. So if it's that kind of case, it is really hard. But when I was doing the PPI work with the people with different cognitive impairments and the carers and things, we use just existing networks that were out there. So there was a dementia inclusion group. I think it's on my slides, I think, but I can get back to you. And the one that we used, and there was Voice Global, that was like a local Northeast one, and there was Essence, which is a local Northeast one as well. And we just basically use quite a lot of different networks and just put out flyers and just talk to a load of people and try and get them engaged, really make it sound exciting.
Great. And that would be my ask for others on the call as well. As you step into that next phase, are there any networks that they have in those areas that could support you to make sure you get the right outcomes, which is fantastic. So I'm going to throw a bit of another challenge and question to all of our panel members around, Jenny's already touched on it, SIM card and broadband challenge. Again, I'll go back to Matt's comment about 1 million people less. How do we collectively try and address that challenge? Matt?
My first thought on that, it's a degree of timing, I think, because we're looking more and more at 5G technology and that just being available as blanket coverage across the UK. I think that's the big kind of fix it all from a connectivity point of view. If we can make that happen. So constantly staying in touch with, I'm working very closely with Cellnex, which is the largest installer of 5G technologies at the moment. We're looking at doing a project with them in the region as well, through the Centre for Process Innovation. So staying close to that, I think, is the most the best thing I've seen so far in that respect.
I'm just going to pull Chris Foreman in. So not only has he put a comment in the chat, and I was hoping that this was going to come out because Chris has told me about this. Chris, can you just ask your question to the panel as well, please?
Yeah, in terms of connectivity, whether it be from a home broadband or for a SIM approach, what I wanted to mention really to help raise the awareness of is something that's very it's known by very few people. Commercially, it's not in their interest to advertise it, but almost all mainstream connectivity providers, such as Vodafone, have what's called social tariffs. In essence, it's high-speed broadband and quite often SIM on an extremely low-cost basis, which are provided to some individuals, to the public, not for commercial use, to the public with certain conditions. Basically, it comes down to your social and economic situation. But ultimately, to give you an example, Vodafone can install I know somebody's got a 1 gig line, you just don't need that. But anyway, whereas I think Vodafone will give you a service up to about 30, 38 meg, which, just to put it into context, there is nothing that needs that. Unless you're a high-speed gamer, in which case you probably have the money to pay for a connection that's faster. 38 meg connection will run any service you wish. On multiple devices simultaneously, it's more than good enough. So these social tariffs are out there. And if you do some basic searching on Google, for example, you'll come across them. In the chat, I've dropped in a link to Vodafone's. So it's a string you can pull on, because whilst it isn't available for organizations, of course, it is something that you could signpost individuals to, because ultimately, if connectivity, the first place of connectivity should be the home. Unless there's a reason not to, which exists. But first place to get connectivity is a high-speed connection to the home, number one. There are others along the line, depending on the circumstances. But yeah, so social tariffs, go and have a look at that lot. And then, and as I say, it is very poorly advertised by all of the providers, because whilst it's a great thing to do and it ticks their box, commercially it doesn't make them a lot of money. So it's one of those things that's out there, but you got to do a bit of digging for it, and that's really all I've got to say on the matter.
Fantastic. That's a great nugget of information. Jenny?
Yeah, along the same lines, really, around the SIM card access. As a charity, Type 1 Kids have been able to access this number of SIM cards. So they are readily available, but not highly advertised. But you must be a charity to access them, as far as I'm aware. So it would be sort of networks and groups on this call who are registered charities or know of registered charities. If you are looking to access SIM cards, that's kind of the route round that you have to go. So it's Type 1 Kids that have, as a registered charity, it's them that have access to SIM cards for us.
Right. Well, thank you for that. I'm going to finish with one final question to Matt, or opportunity. It is a 60-second one because we're running 60 seconds behind, so you've only got 60 seconds. For me, listening to your presentation, you're in that early stage of concept. What is the next steps for you to bring that to life, and what can our audience today help you in doing that?
It's the team, having the appropriate people in the room to reach a decision. So so far I've been talking to individual groups separately, so talking to the banks, talking to the Digital Poverty Alliance, talking to the Cardtronics and the ATM companies. I've never had them all in the same room. So the as I mentioned, the ICB are giving us a lot of support on this. I'm meeting with them next, AJARS and Wally up at the ICB, Professor Graham Evans as well. And through that, we're hoping to get everybody in the room from that point to figure out the solution. Is that 60 seconds?
That
No
is 60
pressure,
seconds. That was perfect. Yeah, I like to put you under pressure, Matt. Less is more. You did say less is more. So I'm only keeping you to your word. So thank you, panel members, today. We've thrown you some challenging questions. We've found out lots. We've connected you in ways that you probably never thought possible. And it helps us to collectively make sure that this agenda item is topical and that we're continuously pushing forward with those things. So we've got some more things in the chat. As I mentioned, we will download that chat function because there's some useful links in there, some useful connections, and we will share that onwards as well with some poignant things. So it's just in terms of the next step. So I just wanted to mention our next forum. I've forgotten the date, Leanne. It's in July. That's all I ever remember, which is terrible.
Oh, you put me on the spot now.
I know, I'm sorry. But we're going to probably have two presenters, because we've got Wally Charlton, who Matt's mentioned, and the Newcastle University big scale research project in North Tyneside with over 9,000 responses to that. So they're going to come and give a good chunk on terms of presentation around that at the next session. So that'll be Goran, Gemma and Wally presenting, and I'm going to ask Andy Wake and the Digital Poverty Alliance to just do a short presentation, because I think we're finding out lots more about that, and they're going to launch their 3 years in the making and what the key things are. So I think it'd be really useful for us to understand what those themes are and how we can make a difference. So it's just to let you know a little bit about that. In terms of next steps, as I say, we'll be Leanne's already put that in there. We'll be sharing the connections. We will have a recording of this. We will also share the slides from our presenters so that you've got that information at hand. And Jenny's plea is please get her poster out, so that we can try and get some more different things in there. So I'm going to very quickly pass over under any other business to Leanne. So Leanne, can you just step forward and have your ask, please?
Yeah, of course. Just obviously with helping Rachel set up all of the digital inclusion forums, we do get a lot of questions, kind of, can we have it on a different day? Would it work for people if it was a little bit later or a little bit earlier? So I've just popped in the chat there a QR code and also the link to the survey. Just 3 short questions: how you found the event today, the preferred day for you for the forum, and just any specific topics that you'd like to see on the agenda from future forums. Feel free to put as many in there as you like. We're hoping to get kind of one that's a little bit more in favour of the other. But again, if you just use the QR code or the link there, you'll be able to I'll collect that data. Anything else that you need from me, if you need any connections or anything, please feel free to use my email address, which was on the link in Eventbrite. If you haven't got that, just give me a shout and I can pop it in the chat as well.
Good. So I'd ask you to do that live, because if you go away and go to fill in the survey, you'll forget. It literally is 3 simple questions. Bear in mind, we've got the agenda topic set for our next session in July. It's about what do you want to get out of this digital inclusion moving forward, so that we've got some real topical areas for discussion or best practice share. And it might be yourself who wants to come forward and actually share what your journey is and how you're impacting the patients or citizens that you're working with. So please do make sure that you share those, so that we can make sure we tailor our future sessions to the needs of what you'd like to hear. So I'll just let you just a couple of minutes in there. And while you're doing that, I would like to take the opportunity to thank our 3 presenters today. So we've heard from Matt Atkinson on Less is More and the ATM project, which I think is a really exciting opportunity. We've heard from Jenny, and we've heard all about type 1 kids diabetes and that network, but how they've linked the right people together in collaboration to get the right technology to people, which is fantastic, and how we shift and scale that across the region. And then finally, we heard from Sarah Wilson and her PhD mission to make a difference for everybody, which is, as I say, that's the whole purpose of this Digital Inclusion Forum. Without you guys, we wouldn't have a forum in the first place, so we always appreciate you coming forward to talk about some of those topical things, to help make a difference and to generate discussion more than anything. My ask to everybody in the audience is take away 3 key things today that were passionate, that you were interested in, and making a difference moving forward. And how do you keep social and digital inclusion at the heart of any projects and interactions that you have? Because remember, there's always a patient at the end, or a social care citizen, or a human, in terms of the services that we deliver across the region. So without further ado, I think I have chaired okay. We're 3 minutes under, so I've done not too bad for a change. If there are any final things, there's a couple of minutes left to raise your hand. But if not, I'd just like to thank everybody for being involved in this Digital Inclusion Forum, and we do look forward to you attending our next session in July. So just checking if there's anything finally. Great, thanks Vic for that great session. Thanks everybody. And you know, well done there from other people as well. It's always hard, isn't it? Putting together a good agenda that everybody gets something out of. But thank you for those positive comments. Great. Well, thank you everybody. You are free to move on to your busy Monday afternoons.
Thanks, Rachel.
Thanks again, guys.
Thanks, everyone.
Thank you,
Thanks, everyone.
everyone.
Bye.